I'm now pleased to introduce to you our guest speaker for tonight. We have with us Professor Colin Depp. Dr. Depp he has many hats. He is an associate professor in the Department of Psychiatry at the School of Medicine of the University of California, San Diego. He is a staff psychologist in the VA San Diego healthcare system, and he provides clinical services, training, and research function in the Aspire Center, a residential treatment program for the homeless veterans who are returning. He is also the Deputy Director of the Education and Training Division of UC San Diego's Clinical and Translational Research Institute, and he is faculty member at UC San Diego's Sam and Rose Stein Institute for Research on Aging. I don't know when he sleeps. And last of all, but it's very important for us, he is also one of our sponsors for DBSA San Diego. So please welcome Dr. Depp.
Thank you. Is the recording on? Or
the recording's on.
There you go. Great. I've already screwed it up, right? So I would just want to say it's really an honor to speak to you tonight. And I think in the midst of all the discussion on technology, I think it's important to note that other people are probably the best technology, and mutual support is probably the oldest and probably the best technology. And so I really am a big admirer and fan, advocate, and supporter of the DBSA. And so I have no financial relationships to disclose, which we have to do in academic conferences these days, is to talk about conflicts of interest and receive funding from a number of organizations. So within a half hour or so that I'll talk, and I'd love to get your insights as we enter the Q&A phases, to talk about just kind of basic ideas that are emerging on the role of patient-level uses of technology in mental health care. And then give you a little bit of data from a completed clinical trial that we did, which focused on bipolar disorder. I have a couple of ideas for future directions, which would be interesting to hear your feedback on. And after I kind of present a kind of rosy picture of the role of technology, talk about some of the downsides of technology. It's not always a good thing for mental health. And so what are some of the critical issues facing not only mobile health technology, but technology in general? I know it's a lot to cover in a half hour, but I think we can do it. So this is a big topic, and even beyond a half an hour, there's lots of stuff going on with technology and health these days. So what I'll focus on really are kind of interactive, patient-oriented technology to support things like self-management of mood disorders, as well as mobile health interventions that use smartphones and texting interventions. Not in this talk are all the other things that involved in health information technology. So that would include things like electronic health records, the kinds of registries that people belong to, whether they want to or not, as part of their medical care, smart home technologies and technologies that actually improve your ability to kind of sustain in your home. There's a whole series of talks around that could be provided, and I'm happy to come back about, and to the extent I can't cover those areas. But we're really focusing here on the kinds of things that you as consumers might encounter, and sort of how to think about how these things arrive. So I'm going to have a quick poll, and thinking about, not just the people in this room, but all of the people in the United States. What percentage of people have a cell phone, and how many people have internet? What would you say for the first question? Cell phone, you can just shout it out. I know we're not supposed to do this.
74.
74?
60%.
60 going down?
80.
100.
80. 100, okay. There's no prizes, by the way, unfortunately, if you get it right. What about the internet, would you say? What would you put that at?
95, 45.
82.
45. Okay, this is a pretty big gap. Okay, well, the right answer, at least there is no right answer, actually, because this is from 2013, and this is more so nowadays, right? So this is a number that's changing by the minute. So about 91% of Americans have a cell phone, which is more than the number of people that have, I think that there are more cell phones than toilets in the United States. That's extremely true in developing countries as well. The internet, 86%, although not everybody has kind of what we consider broadband. Basically, we're at the point at which most people have a cell phone and internet. There is still a digital divide with older adults lagging, but the fastest growing adopters of technology are people over age 65. And just to kind of put this rate of change in technology into perspective, this is just kind of a nice chart just to showing how things are accelerating. So it may be difficult to read, but I'll sort of basically what these bars represent is the years it took before 1/4 of the population, the American population, had adopted a technology. So electricity was around 40 years. It took 40 years for 1/4 of the Americans to take on technology. And telephones around 30 years, television a little less, the computer around 20%, mobile phones only about 10, and less than 10 years for the mobile web. So basically the idea here is that we're kind of grabbing on to technologies at a much faster rate than our great-grandparents and their parents. And this, who knows where this is going to go in the future, but this all has huge implications in the healthcare space, is also in the way that we kind of treat mental health care, and I'll sort of get into that in a bit. So conceptually, this is an article that I was fortunate to be a part of. There was a think tank that was part of an NIMH work group, which is the National Institute of Mental Health. Basically, the idea here is that there's lots of roles for technology, from the kind of continuum for when people start entering mental health care all the way to where they sustain it. So if you're just seeking mental health care, you could think about things on the web or electronic decision support guides that can help you decide what kinds of treatments to get. And then that would kind of extend to sort of choosing amongst treatments. For engaging in treatment, there's a number of resources nowadays for phone and telehealth services. So the VA is actually a fairly big proponent of these, and I'm not sure what percentage now, but it's a fairly large percentage of veterans that access mental health care without either leaving their home or actually through the web or through telemental health portals. So basically seeing people far away in a clinic. There are mobile devices for real-time, kind of real-place interventions, and I'll describe what that means. And then there's also computer-based or internet-based therapies. And then for staying in care, for people that kind of live with illnesses that are chronic, text message reminders, online forums that kind of support this. The DBSA has its own set of electronic tools that are actually quite nice, and I would encourage you to check them out. And then basically things that basically kind of try to keep people staying in care. So there's lots of potential ideas here, and I think one of the themes of the talk will be that the potential hasn't quite caught up to, I think, real clinical applications. There's a lot of people excited about this area, but yet not a whole lot of evidence yet. So what about mobile health interventions, so smartphones? And this is an area that I've been working on for about 4 or 5 years. And I was attracted to this area because one is that in working with largely veteran population in a clinical setting, it did seem like the idea of parking in this, just even getting to the second floor, it just seemed like a particularly onerous task for a lot of people, including myself. And so potentially mobile devices could deliver care outside of the clinic setting, and particularly for people who are older or have disabilities that disallow transportation, this is attractive. You also could potentially reduce or extend face-to-face intervention. So in addition to meeting with somebody for 10 weeks or 8 weeks, you could expand that over time or improve the ability to maybe remember things that you talked about in the session once you leave. So the idea is potentially this could compensate for forgetting, which happens to anybody after you leave the doctor's office. And I'll talk a little bit about this, but some ideas that maybe we could, instead of comparing ourselves to the average person with X illness, with bipolar disorder or depression, maybe we could be comparing ourselves to how we've been in the past. And so you could potentially use the data that comes from these devices to, which people do with mood charts, and now it's eminently possible to do with the computer, identify patterns within yourself that might predict the future and how things are going, and then prevent bad things from happening. So this is kind of what a mobile health intervention looks like. And so we're all familiar with apps, right? You have those on your phone. And what goes into that, right? And so you have a couple of things. You have a series of algorithms that dictate what you see on there. You have a number of different communication channels, be they email or text or web-based things like pictures. And then there's a server, and then some data processing that happens, and potentially there's a person on the other end. Not always, right? With most apps that you get on the App Store, they're not typically associated with the real person, but increasingly we're seeing that a lot of the research-based interventions have actually a person, so they're actually monitoring the information being provided. The VA, for example, has something called the Health Buddy, which involves kind of a chronic interaction and just basically checking in on a repeated basis with veterans that can't make it to clinic appointments. And those... Just hold on a second. So there's lots of options for delivery of mobile health interventions. You could use text messaging, and there's been a lot of text messaging-based interventions that focus on all sorts of health-related topics. Smartphones, there's tablets, as well as in-home messaging devices, which are actually devices that are manufactured just for remote care. The advantage there being that they're there's less risk for loss of data or privacy losses. So how many sensors would you guess are on a mobile phone, would you guess, that's actually collecting information from your day-to-day experience? 5, 10, 15. It's actually 38 different sensors on a mobile phone, and this is increasing on a day-to-day basis. So we can also ask questions of people and sort of have them perform ratings, but we could also collect data from a lot of other things. So from a research perspective, this is really exciting. From a consumer standpoint, we'll wait and see, I'd say, but you certainly have the accelerometer, which gauges how often people move around, which certainly is related to mood, how much light that they're exposed to. There's some researchers at the University of Michigan that are looking at your vocal tone as you speak, and that's being associated with mood. So people who are more depressed tend to kind of blend those vowels together. So people have looked in this. GPS, where you are, have you left the house? Those are all kinds of things that could be associated with mood. And then there's lots of other things that people are looking at, and particularly at UCSD. I was just talking about a sensor that's actually like a tattoo that you put on your arm that monitors all kinds of biomarkers. There's a camera that records your day-to-day experience. All of this is really kind of research-based at this point, but maybe in the near future, if it's helpful to people, it could be part of clinical care. There's actually even an EEG that you can walk around with 2-lead EEG that can monitor your brain waves on a continuous basis if you wanted that to happen. So so that's kind of what we could do. That's what the basic technology is where it is from a mobile health standpoint. And there are a number of different apps. I don't know how many people have tried any of these. I'm sort of picking out the ones that are particularly vetted by the VA, and I know they're particularly good. I can attach some web links that you can go to directly get these. And I think all these slides are around, but these are all things that have been developed in the VA setting or through contract agencies that are all freely available. And they really just kind of do a couple of things. They just kind of either help you monitor your symptoms, remind you to kind of engage in healthy coping strategies. There's one I really liked, which is basically you kind of list it's like a sort of a slot machine, but for pleasant events. So basically you're trying to get yourself maybe potentially to engage in something enjoyable, which can be potentially useful for someone who's depressed. There's really nice kind of focused breathing and meditation relaxation apps that are out there. I didn't necessarily want to go through each one because I think it's really largely a fairly personal decision which of these you think you like, if you like any at all, but I think it's good to know what's out there and how to find it. So I'll just kind of run through some results from one particular clinical trial that we completed. And so we're interested in bipolar disorder. I've been interested in psychotherapy for bipolar disorder for a long time. And one of the things that I've noticed in particular from studies that we've done in our domain and then also nationally relevant studies is that people don't sort of get the full dose of therapy. So often we have kind of 20 or 30 session protocols, which, for the most part doesn't necessarily meet the kind of needs for real world people who have to actually pay for these kinds of sessions. And so what we've done, we're sort of concerned that people either drop out or they don't attend all of it. And then if you look at the actual trends this is a little bit older data, but in how many people with psychotherapy actually get psychotherapy, it's declining. So at the same time, we're getting evidence that suggests that these treatments really work and they do seem to affect depression. The actual rate of in-person psychotherapy utilization is going down. And that's not good. So I think what we need to do, one option is to take very brief treatments and try to extend their effects. And so we developed a kind of a pilot intervention called Personalized Real-Time Intervention for Stabilizing Mood, which took a long time to come up with that acronym. But the idea is to try to take very brief psychoeducation, things that I think probably a lot of people who are experts with bipolar disorder have already kind of mastered, but this idea that basically one of the things you'd want to do is identify things you could do if you became depressed or things you could do if you were encountering an early warning sign of an illness. So, for example, a lot of people, it's sleep loss. And then we work with them individually to kind of optimize some ways that they would like to cope with things if they encountered either that early warning sign or that symptom. And then the twist is that with their mobile devices, we had them identify things that they could tell themselves in the future were they to encounter that symptom or early warning sign. So in a sense, you're having people kind of coach themselves into the future in a fairly simplistic way, but I think a reasonably powerful way, basically with the idea it's really hard to disagree with yourself in the future, right? And so you may have other people kind of nagging you to get out of bed or something like that, but if you said it to yourself in your future, that's actually maybe more powerful. So this is an example of the kind of thing we use. We use this fairly scripted way of describing these statements. So, for example, we have people identify a specific situation, a specific behavior, what they would do in that moment, and then a benefit of doing that behavior. So each time the person rated their mood on a day-to-day basis, this would come up, and they saw it, and they kind of hopefully reminded themselves to do just that. So I don't know if you're familiar with how clinical trials go, but this is kind of a middle-sized, maybe smallish trial of about 90 people with bipolar disorder. And what we did was compare people with 4 weeks of psychoeducation, which is the same protocol. So we had people kind of coach themselves, identify the same coping statements. And then one group got a mobile device where they monitored their mood and then were reminding themselves just with this device. And in the other group, we had them just fill out a paper and pencil mood chart. So these are very similar interventions. And if you were to design a clinical trial, you probably wouldn't do this, right? You wouldn't make them that similar. Our primary outcomes were basically ratings of depression and mania assessed at 6 weeks, which was mid-treatment, 12 weeks after treatment, and then 24-week follow-up. And so we were surprised and encouraged to find that in the people that completed this treatment, and maybe don't necessarily worry about the scope of these numbers, but basically what we found is that a fairly large effect size, which is, or a middle size effect size, which is large for a kind of active control like we used at midpoint and at 12 weeks in terms of better effect of using this device. Unfortunately, at 24 weeks after we had taken the devices, these were our devices, back, those depressive symptoms got worse. And we actually saw the same pattern to a lesser extent, but in the same direction with manic symptoms. And so what we've surmised was we hoped that people would, by monitoring their symptoms and then reminding themselves to engage in positive coping behaviors in the moment, they might continue to do that on their own, sort of automatically. And I think what happens, just like any sort of other reminder kind of device, like a medication reminder, is that if you take the thing away, you just forget to do it. It's sort of like an exercise app. They don't necessarily assume that you're going to remember to engage in exercise. You're just kind of getting in the habit of this. And a lot of people use mood charts in this way, just to kind of keep themselves focused on what it is that they're trying to do. Okay, so I have a few more slides on this trial. We were just wanting to see if there were the actual data that we're getting on the phone. People are entering their mood state, and what we found is, you get a ton of data out of people's daily ratings, and what we found is that people spend about half at the beginning of the trial. About 38% of the time was spent in a kind of even state, and at the end of it, around 53%, which marked a significant improvement. And we also saw that people that got better, at least according to the depression rating scale, seemed to use the device more often than people that did not. So this is by no means kind of the be-all, end-all in this, but we were encouraged that at least with people with bipolar disorder liked the intervention, and they did seem to benefit in terms of bipolar depression, which is a particularly challenging aspect of the illness to treat. So we've tried to do something a little different we have a different trial currently. If you're interested, there's my email, or you can also contact me by phone. But we're kind of trying to get at not just coping statements, but sort of beliefs around things like socialization and medications that we hope, I think, has a bigger, more long-lasting effect rather than just a reminder system, which is a little bit more simplistic in our first trial. Okay. So I'm going to go through a couple of future directions, which I think are kind of where this field could go, and I would love to hear your feedback on this. This isn't necessarily my thought, but as I mentioned before, the whole field of mobile health is kind of reasonably at a simplistic stage. Most of the interventions really just do two things. They monitor some behavior, like a physical activity or smoking, for example, and then if you do that behavior or don't do that behavior, there's a response. So if you smoked that day, you might say, why did you do that? If you didn't smoke, great job, right? So that's pretty straightforward. So consider this as the example, and we can do this with the technology. So what if your mobile phone said, since you're in a bar now, the last 3 times you were in a bar, you reported a strong urge to smoke. Since you often smoke when you drink, you might want to limit your drinking. That would be probably pretty annoying, but your phone could, right? You might help, but your phone would actually be able to know this because you told it, basically you have data on whether you were drinking when you were in a bar, you have data at the same time when you were smoking. This phone would then know about you that you smoke often when you drink. And it would also know that you're in a bar because of the GPS. And so there's a lot of fairly sophisticated processing that could go on, and your phone could start to rule your life. And so before you throw it away, this actually might be a more personalized, maybe more compelling kind of intervention strategy. We were just talking a little bit before the meeting is what I'm really interested in is for diseases like bipolar disorder, we know that there's a lot of differences between people, but then at the same time, people tend to have the same warning signs over and over again. And so what we'd like to be able to figure out, based on individual changes, so changes in sleep, for example, what are the precursors for things like crises? And how can we identify these precursors at a time prior to when we could do something about it, right? So you'd want to be able to space that out. And that becomes a fairly complex mathematical problem. But actually, we have these great statisticians now that can take streams of data, just like Amazon is able to predict what you're going to buy, or Netflix is going to tell you what movie you want. You can look at all this data and then project in the future, potentially, and in this case, predicting crises based on just a couple of variables, sleep and negative mood. So then, potentially this is all 2 or 3 weeks before the crisis. And so what we could do is then say, hey, you're at risk for a crisis, and then here are some things you could do to potentially increase your odds of avoiding it. This all depends, though, on whether or not you think there's something you can do about it. So if somebody told you you're going to get a flu next week and there's nothing you can do about it, it's not necessarily going to improve your mental health or your ability to kind of function. But this whole field, I think, is something particularly going to be emerging, this sort of idea of prediction in care. I'm going to skip this one slide. So that, there's lots of excitement about this kind of stuff. Well, what about the other side of technology? How many people think technology is a good thing for mental health? So what about these are some broad issues, and I'll kind of start with that. But there are also issues around privacy, oversight, and quality control. Whether these interventions actually work, whether they're evidence-based, and then what do we do with all this data that we're getting? So thinking about technology, this is actually data from all Americans. So they're not all Americans, but just a very large population-based sample of data from people who describe their previous day. And this is just the illustration of maybe why technology is not necessarily improving our well-being. So this is a questionnaire that basically asks about what you did previously the day before, which is a little bit different than asking people how you generally feel. So when you ask people when you're happiest in general, usually people say it's when they're with their kids. But when you actually look at these kind of data in terms of how you spent your day yesterday, that's usually when they're most miserable. So this is hopefully getting a little bit more accurate. So this is what people are doing when they're least happy, at least in this sample of about 4,000 Americans, not necessarily with depression. When you're younger, the least happy activity is work. And that sort of drops out. But look up at the top. Computer, TV is pretty high up there. And the only reason these people are not liking computers is because they don't know how to use it, right? So they're not doing it. So this is fairly consistent across the lifespan. What about when people are at the top? So exercise, socializing, being around other people. It's fairly consistent all the way across the lifespan with kind of working for those few people that are doing that into their 70s is actually a pretty enjoyable activity. But then you look at the actual frequency of time that people spend watching TV. Even though we don't like it, we don't enjoy it, the actual numbers in terms of frequency of time go up pretty steadily across the lifespan, such that when you're in your 70s, the average is around 25 to 30%. So I think this suggests that TV is not necessarily making our well-being better, and that potentially if you replaced it with some other activities, we can increase national well-being in a sense. This is an area I'm particularly interested in and I don't know much about. But what about social media or Facebook? Do people think it's useful, helpful, or depressing? And so this is the quote here. If you can't read it, it says, "May your life someday actually be as interesting and awesome in real life as you pretend it is on Facebook." So what does the data say? So there's actually mixed results with social media use and depression. There does seem to be some signal for people who use more than 2 hours a day of Facebook and other social media linked with mental health problems. But with adolescents, it's kind of mixed. So I think one thing clinically, in terms of the phenomenon, I see people say that they feel down, and then they're by themselves, and they say, I will go look online at what everyone else is doing on Facebook, and then they forget, and depression makes them forget, that other people are not necessarily posting their real lives on Facebook, but they compare themselves to other people online who are basically posting pictures from 9 years ago, and they're describing things that are completely, they forget this is a marketing tool and not a real accounting of behavior, and then they see these other people succeeding, and when they're not succeeding, it makes people feel worse. And so, they do this right before they go to bed. And so this is not a good recipe for mental health and good sleep and self-esteem. So I think, there's sort of downsides of it. However, there are a ton of really cool sites that are really emerging out there. Patients Like Me, blogs that are really basically communicating research in a way that's consumable by people, advocacy and mutual support tools and things like this. So this is, really kind of gets at the marrow of the idea that, technology is not necessarily good or bad, but it is making a big impact. Just run through a couple more slides, but So there was a recent study that looked at all the mobile health apps for bipolar disorder, and only about, if you just go to the App Store, and I could send you guys that link, but basically only about 10% of those apps have some privacy policy in there. So who knows what happens to that data? Who knows what happens with any data, even if you have a policy, but we're thinking about these apps in the VA. We were asking about, does it store information about you? Does it ask you about personally identifying information? Does it take data from any other sources? And this is really not easy to determine if you get from a website, and it's also not easy to determine if you use something at Kaiser either. Or I'm not bashing Kaiser, but the idea that there's a lot of complexity in these kinds of use agreements that are difficult to interpret. Not many apps out there are FDA regulated. So to be FDA regulated, you have to have a clinical trial and show that these things are effective. There are some, though, but only those that alter the course of treatment. And unregulated apps, which is most of what you'll be able to find in the App Store, in fact, all of it, would be able to basically operate in anything that improves self-management or allows access to medical records or automates simple tasks. So really, we're not going to be able to get FDA approval in a sense because they don't have time to review basically what's now about 100,000 health apps. So this is a research study on pain, but all the apps for pain. But I think the same is true for mood disorders. There are 100 apps currently available in general, and this is a study that looked at just those that had to do with pain. What they found was there's basically no correlation between those that come from researchers and that come from that are on the app stores. They're very different entities, and they're actually, unfortunately, and I'm at this point guilty of this, but for a variety of reasons, is there are a few research-based apps that do seem to be effective actually online that you can access. So this is a gulf that I think is an area of important advocacy, I'd say. Okay, so just in summary, and I'd love to hear your thoughts on any of this, but there are a wide variety of mobile applications, both for mood disorders and for other serious mental illnesses. PRISM seemed to be more effective than active control in addressing bipolar depression, which I think is a reasonably big deal, and so we're excited about that, and we're continuing along those lines in other studies. Mobile technology does seem to be useful for getting potentially to people outside of the clinic setting, taking brief treatments and making them bigger, stronger, and better, and potentially for preventing things in the future that would come from predictive kinds of analytics. But there's lots of unresolved issues, and I really think that this is an area where being a smart consumer and then also being an advocate is important in terms of kind of being able to state which things kind of violate the kind of basic principles of good mental health care and mutual support. So from that, I will end and say thank you for your kind attention. I'm happy to answer questions.
Okay, so let's give Dr. Depp a few-minute break while we prepare questions using our index card. So I'm going to turn the lights on. So anybody need an index card? Oh, you ready? You're ready.
I'm ready.
Okay. So again, for those who came in late, we're going to have 3 rounds of questions and answers. First round, we use the index card. Second round, we raise our hands. The first 2 rounds are going to be recorded, the audio. The third round, we're going to turn the audio recording off, and you can ask whatever questions you want.
And if people want to get up and go,
What?
if people want to get up and go or whatever,
Or
they
the
want
middle?
to
Yeah, they're welcome.
Okay.
Just be quietly.
Right.
We can start. We have more questions given to me, and I think it's better for you to just
Pick randomly or read
pick
them?
randomly. Yeah.
Okay. Well, I can get started.
We can get started.
Yeah. Okay. One comment. I think mobile technology may be more helpful because it signifies a contact with some kind of provider. So whether or not there are people on the other side of it. Yeah, there was a recent clinical trial that just had no one. It was just a purely self-monitoring app. It was really an amazing technological achievement, but when there was nobody there, I think it wasn't effective. And whether that was the reason why it wasn't effective is unknown, but I think what we don't want these technologies to do is to replace people, right, and to cut costs and so forth.
No,
and so,
but it does mean that, if you can only get in to see your psychiatrist every 2 months or something, and you need that extra support, you're more likely to feel that you're supported in a way, even though you're not getting answers from them, but still there's a contact.
I think there is something to that.
If you're on your own, it's like, well.
Yeah, I mean, I think in our trial, we did not do a whole lot of sort of responding to, but people really do think having that belief that somebody's paying attention to how you're doing is a very critical thing. Yeah. Regarding the breathing sensor, how does this work? Lung capacity. So you certainly can get respirations, and I'm not necessarily the expert in that, but there's certainly those bands that go around you that can get respiration with basically kind of mechanical increasing of your chest. There's actually technology developed at UCSD here where you can look at somebody's video and then determine their heart rate, because your face kind of does this little jiggle every heartbeat. So there's a lot of very sort of striking stuff that's out there. Specify the psychotherapy that is used, cognitive behavioral therapy, DBT, or psychoanalysis. So in our trial, we've largely focused on CBT, but there are lots of what we would call third wave kinds of apps, so that really focus on mindfulness and basically maybe things that are more consistent with DBT that are there. I don't know of any specific psychoanalytic apps, but I'm sure that's possible. It would be interesting to imagine such a thing. What's the difference between mobile technology and home health agency or home health technology? So I think the idea here is that these are, what I'm referring to are standalone apps or devices that can be on your phone or a phone that you have through your healthcare. Home health would be sort of a wraparound service that could be built around that. So in the VA, for example, we have something called CCT, which I'm not necessarily care coordination health technology or something like that. So they actually have a person who's basically a home health person who's monitoring the data that's coming in. And so there are kind of whole services that can be wrapped around the technology. But mobile technology would be more specific to the actual, just the technological element. How does DBT and cognitive, I think probably CBT here, compare to your system? Doesn't it take a long time to change a bad habit or a thinking pattern? I agree with that. And so this idea that most of the time when you think about an app, that this is something you kind of mess around with for a little while and you put down, and doesn't it take a while to change a bad habit? Supposedly 60 days, I think, is what has been, that's the average time to change a bad habit in a sense. But I think you can potentially divine some associations between kind of how you feel and what you do in a day with these kinds of devices. And that over time, in several months, I think you could probably learn from that data and make some changes in terms of kind of how you operate in the day-to-day lifespan. I think the nice thing about these technologies is that they can go on forever. So you could have this web-based program basically continue indefinitely and without essentially freely. And so that's one added benefit, I'd say.
You get all the questions?
I think I did, didn't I?
Oh, no, we have a lot more.
Oh, shoot. I don't know what happened, man. Thank you. How much do apps reduce hospitalization? Well, I think this would be a great research study. Reducing hospitalization, I think, is, this is not something that people have really looked at in terms of the potency of these. So most of the studies that have been focused on just reducing symptoms. Reducing hospitalization, you have to get a lot of data. This VA device I kept referring to does seem to reduce hospitalization. So you need really large samples for that, and so it has to be part of the healthcare system. for most healthcare systems, don't really have either wherewithal or the kind of coordination to kind of deliver these technologies as part of care. I think that's a great question. In California, the rate of rehospitalization within 1 month of leaving a psychiatric hospital is 23%. So about a quarter of people within the month will come back to the hospital. So that's a particular period of time that we're really interested in reducing rehospitalization or hospitalization in general. Is Lumosity helpful to improve mood? And do you know if it is provider monitored? I'm pretty sure, and I'm almost positive that it is not provider monitored. This is a commercial application that is meant to improve cognitive abilities by doing sort of brain games. What in general the literature on brain games has shown is that you do get better with brain games. So you get better at doing crosswords by doing crosswords. So they don't necessarily improve your ability to think and so forth to the extent that the manufacturers typically claim. I don't know if there's any kind of Lumosity-based trials that are out there. And so so if you enjoy, I think people have generally said if you enjoy it and you think it's working, it probably is, right? It might reduce your cognitive complaints. It may be better than watching TV, for example. So it's probably harmless, but I think believing that it's going to boost your WIQ and so forth is probably not likely. How can we find the approved apps, the ones that I'd mentioned, where they posted? So since I've just sort of handpicked a couple that are that I've seen, but this is actually I think our big role for DBSA. I don't know of any good, and I think for peers as well, but I don't know of any sort of formal vetting process for apps that are kind of consumer approved that have privacy policies that seem to have some basis in efficacy. So I think that's something that's lacking, and I think is really an important thing. The ones that I mentioned in particular, when I update these slides, I can just send you the link. Will be in the slides that you can just get to, and it's reasonably easy to see it. But if you just search for, I believe, kind of VA apps, mental health apps, you can probably find it. Is there an easy-to-find use database for research studies for bipolar and depression? Yes and no. So there is something called clinicaltrials.gov, which will show you all of the research studies on campus that have a clinical trial, or anywhere in the country, and you can search for things like depression or bipolar disorder. And beyond that, there's a service at UCSD called Research Match. If you look at researchmatch.ucs or UCSD Research Match, that is linked to our institutional review board and the people that review the ethics for all the studies. And allegedly, all of the studies they should be able to link you with a study if you're interested in those. So
that concludes our first round of questioning. So the second round is you raise your hand, but the audio is being recorded. And after we go through the second round, I'll turn off the audio, and we'll do the third round without the audio recording. So, any questions?
Sure.
I have a suggestion. We're having a lot of trouble getting providers to monitor patients who are on atypical antipsychotics for what has been recommended for probably 10 years now, such as blood pressure, blood sugar, weight, and certain labs. I think using the mobile app would be a great way to have some of that happen at least, and notify both parties that here 3 months or 4 months have gone by, we need to do that again. Right. Because right now it's hardly happening at all.
Yeah.
That would be a great connection.
Yeah. I mean, I sort of focused on apps that are for consumers, right? But there are a number of ones that are directed towards doctors that are helping.
Well, it's important to us too. If we're taking the meds and we know that all the risks and imminent dangers, and nobody is
right. Yeah, and so that the app in a sense would be something that helps to remind places schedule on things and making sure you're conforming to guideline care. The VA sort of embeds this sort of thing in their medical record. So we get routine screenings. And I'm not sort of saying that VA is perfect, but I mean, screenings for suicidal ideation or suicide risk, we were flagged to get that kind of thing. And so I think providers are the same thing, but in a private health system, there isn't that sort of thing. I think you're in first in the back.
I was curious. You had mentioned both the fact that social media can correlate with depression or large amounts of social media use, but I suppose this also applies to the tracking of what activities people did when they were unhappy. I'm wondering if anybody has looked at whether or not those are causal, or which direction the causation is, because I know when I'm depressed, I'm more likely to spend time watching TV for hours or on the computer for hours, just flipping through my Facebook page. So I'm wondering if we're confusing cause and effect there.
Right, no, that's a great point, and those are not, I mean, there have been some longitudinal studies, but that are really difficult to tease that out. I mean, there's studies that would follow people and look at TV use at one point and then in the future risk for things like cognitive decline and so forth later on, which isn't perfect for causality, but yeah, I mean, I think it really makes sense for people, and that when you're feeling more down, you're not going to be outside, and you're typically, really that's sort of what to do to make the time pass, and so that's a good question. Yeah, and I don't think that's resolved in any regard. Yeah.
And I suppose an app could be useful for that if it monitors mood at a more, or biorhythms or whatever at a smaller level. You can see it sits down in front of the TV and becomes increasingly more depressed over the next couple hours. I think that would be more suggest a causal.
Right, and people, and then some experiment where there have been some experiments where they've basically done just that, where they've limited TV time, right? And so they basically, and they mostly in the sedentary behavior space, so that with kids, for example, cut the TV down, exercise goes up, and in theory exercise, but not necessarily as a treatment per se for mood problems. So that would be an interesting study. And then you were next, and then we can go.
Yeah. Do you foresee a time when clinicians can use live data from a mobile wearable device that would monitor an oncoming suicidal depression or a psychotic episode, and human on the end can respond in real time?
I mean, that is what a lot of people are working on and they're interested in. I mean, so people look at scanning medical records or any other types of information data from these kinds of things. This is an area where there's a lot of actual companies that are sort of looking into this and see this as a big frontier. I think there's a lot of challenges for that, and that one is that clinicians, they're already, I think, probably feeling overburdened by calls about actual crises, and then predicted crises is another kind of layer, even though that's what we should be focusing on in terms of prevention, is that you'd identify periods of time where people are more at risk and then doing something rather than actually when they get to their crisis. So I think that I think that all the data is there that we could potentially, if these are predictable illnesses, which I think most people would agree that there's some ability to predict, then we have all the data we need. Then we just have to come up with systems that work for people, for clinicians, and then actually what you could do to prevent those crises within our current mental health system. So I think it would be years from now, maybe decades, but I think it could be possible. Yeah.
I guess the question is kind of garbage in, garbage out. Do you see the applicability of the apps primarily in the recovery stage? Because when someone's manic, we get all sorts of confused answers from them, and a lot of times they do not tell the factual story. So.
Well, so that's where people are looking at. They're looking at other proxy indicators, like how much activity, how much movement people are making around, or other indicators of how people doing if you were to monitor someone. But then the absence of responding is also kind of data in and of itself too. If somebody were not responding to the home device that we use at the VA, somebody will reach out, and so they could be in a manic episode at that point. So I think most of these technologies are really kind of geared towards identifying people maybe when they're in a state in which they're still participating, but yet not quite at a full manic kind of episode. Yeah, I don't know if that answers your question. But,
I was just kind of wondering if this would be able to work. Then wouldn't it really need to be coexisting with the medical field too, or and like the mental hospitals and I'm just wondering if is there some way that, and this is probably something that might be far away, but where you could put it in like a box, maybe the apps or something, so that they can give the patients this on discharge.
Yeah. And I think that's where, right now, I think that's a great question. And so a lot of where the field has gone is we're sort of beyond the state at which we've tested this. Some people like it. Some of these interventions are effective, but it's been sort of totally separate from the actual kind of clinical system of care, hospitals, and it's not. The other issue is sort of who's going to pay for it. Is it the consumer, or is it the insurance company, or is it the state? And to keep these things up, and who's liable if it doesn't work. And so this is all stuff that's not, it's sort of begun to appear in kind of routine practice, but eventually, in order for it to really have legs, so to speak, it will have to be really integrated with clinical care and actual service providers and people and peers potentially too. Yeah. It's interesting though, I work in, there's a number in low and middle income countries of places where they don't have any clinical services. This kind of stuff is really becoming kind of more the de facto healthcare, and so there's been a lot of research in that area. All right.
Okay, are we ready to enter into the third phase? Okay, so we're going to turn the audio off.
Oh.
Okay.